Good morning. If anybody needs to get a seat, now is a great time. So just to give you some background on the idea for this session, at BC Children's Hospital, maybe 2 or 3 times a year, we get a call from an adult center all across the province. We have a patient, maybe they've got X syndrome or Y condition and they're growth restricted, maybe they're 30 to 35 kilograms and they're in end stage and they need dialysis, and I'm not quite sure using my typical prescription for the adult patient is going to be appropriate for this person. Can you give me some advice? So between that and the little old ladies you get, I think there's some things probably that you can learn from the pediatric program. And we're very lucky this morning to have speaking on this topic Dr. Elizabeth Harvey, who is an associate professor of pediatrics at the University of Toronto. She's been a pediatric nephrologist at the Hospital for Sick Children for almost 30 years. She's got clinical and research interests in improving the longevity and good health of children with CKD and dialysis, and improving the tolerance and effectiveness of dialysis in children. She's got a wealth of knowledge and experience in managing acute and chronic renal replacement in patients of all shapes and sizes. And we think we have much to be learned from her experience as she presents to us on the topic of dialysis prescriptions for Petite patients. Dr. Harvey?
Thanks, Janice, for that introduction. You're going to have to bear with me. I've got a little bit of a froggy voice that I can't do anything about. So thank you very much to the organizers for inviting me to give this talk and share with you 31 years of looking after patients with renal disease, from newborns right up to 18-year-olds. I'd also just like to acknowledge my colleague Colin White, who's a recipient, much deserved recipient of the Wilma Crockett Award. And I have to say that Colin and I have had many fruitful discussions over the years, both on education and patient care. In the vein of disclosure, I have research funding from Fresenius. I'm a co-PI, totally unrelated to this talk. And we use both Baxter and Fresenius machines and supplies for our dialysis and PD patients. And anything I talk about is related to our clinical experience and in no way any endorsement of a particular company at all. And finally, I want to say that all of the clinical photos, so you're in for a photo shoot here today, guys, they're all used with the express consent of the patient or the parent for purposes of this presentation. So we're fond in pediatrics of saying that children are not small adults, but it's equally true that small adults are not children. But as Janice says, sometimes worlds collide, and the adults end up with a very petite patient, and we get the panicked phone call, help us prescribe dialysis for this patient. And I think that's a little bit more prevalent in the hemo world than it is in the peritoneal dialysis world. I think that they're a little bit more used to scaling for small sizes. So the objectives here are to familiarize the learner with some of the ranges of bloodlines and dialyzers that we use in pediatrics, as well as vascular access, and then in PD to review the principles behind prescribing peritoneal dialysis. And I'll have to say that I think for the adult people in the audience, this may just be a reaffirmation of why you're adult nephrologists and adult nephrology nurses when you see the size of some of these patients. So on to hemodialysis. So in order to do hemodialysis, you have to have an access. I feel very cowed coming on the heels of that last presentation. I have to say that our fistula rates are abysmal, and that's a variety of reasons. One is because we have very small patients. They're transplanted very quickly, and we really have no in-house expertise with creating fistulas. But just the week before I came, one of our amazing interventional radiologists has come to us and said that, this new endovascular device, it's smaller now, and they're going to come and talk to us about creating fistulas. So I look forward to a new era of vascular access, because I know we kill vessels, and we've gone completely away from subclavian lines, but we still do have an incidence of vascular stenosis. So you need an access, you need a machine, you need an extracorporeal circuit, and a dialysis prescription. And that extracorporeal circuit has to be between 10 and 15% of the patient's blood volume for stability reasons. And we start with 10%, and then if the patients are stable, work up to 15% if they'll tolerate it. So we use 2 machines currently for the bigger kids, and a big kid is more than 10.5 kilos, guys. That's a big kid. We use a 5008 machine. And then for the smaller patients, we use the 2008 still by Fresenius, and that's because there's no pediatric software or neonatal lines for the 5008, and we're hopeful that those are going to come soon. But you can use any machine that's capable of using the particular lines. Vascular access is the search for the holy grail in pediatrics. We're always searching for new lines, and the new kid on the block that I just want to point out there is the one down in the lower left-hand corner, that's called the BioFlow Duramax, which we're using in the bigger kids. It's got a little kink at the end that's supposed to keep it from abutting up against the vessel, and the preliminary reports of its anti-thrombogenic properties actually appear to be true so far in our limited experience. So we divide our access up into whether it's an acute access for patients who need acute dialysis or who unexpectedly come to us and are very unstable and not suitable for an anesthetic. We don't put in our lines ourselves. They're all put in by interventional radiology with an anesthetic. And so for a baby as small as under 5 kilos, about the smallest patient that we can put a central line in is about 2.5 kilos, and that depends on the interventional radiologist. So we go from 5 kilos with a 6.5 French gam cath up to 40 kilos with an 11.5 French Maharkar. And sometimes the interventional radiologists will put these in the neck, but they're stiff lines. And so if we're going to go into the neck, we actually prefer to put in a tunneled line. So for the under 5 kilo babies, we're putting in an 8 French Med Comp. These really are, I'll show you some x-rays, they're garden hoses in these small vessels. And so there is a trauma to the vessels, there is a risk of thrombosis, but if that's what you have to do, it's what you have to do to dialyze these children. Between 5 and 19 kilos, we use a 10 French Med Comp, then we go to a 12 French, and above 35 kilos, you can put an adult-sized dialysis line, and we're currently using either the Palindrome or the BioFlow Duramax. And we phased out the Quinton perm caths. Not that there's anything wrong with them, but the interventional radiologists don't like to put them in. They say that the hole that they have to make in the vessel in order to accommodate the shape of the line is bigger than they like to. The next thing that we need is an extracorporeal circuit, and this is where we get into some real pediatric specifics. So we're trying to make that line, that extracorporeal circuit, less than ideally 10% of the patient's blood volume. So you're not going to be able to see this from the back of the line, but we have a kind of stable of dialyzers that I'm going to show you in more detail, and the 2 most important things about them are the priming volume and the surface area of the dialyzer. So for the teeny tiny babies, we have 2 dialyzers. This will blow you away. Their priming volume is either 17 or 18 mils, and they're 0.2 meters squared surface area. We use all polysulfone dialyzers. They're little. They're very little, but so are the patients. And then we have to have a range of sizes that's going to take us from the 3 kilo baby right up to the 103 kilo teenager or bigger. And so we have a series of the FX dialyzers that go from a priming volume of 32 mils and a surface area of 0.6 up to 138 mils or a 2.2 meter surface area dialyzer. And then because patients don't always behave like they should, every now and again we get a patient who will have an allergic reaction to a particular dialyzer. We have a couple of other dialyzers in our armamentarium to use when we require them. Sometimes dialyzers are on back order, and it's a never-ending problem to try and keep those tiny dialyzers in stock. We have a series of 4 different bloodlines, depending on the machine that we're going to use. And so basically, the smallest lines that we have are the neonatal arterial and venous lines, which top out at 27 mils for the circuit. The pediatric, and you can't do blood volume monitoring with those lines, which is sad because those are the very patients that you really want to know what's happening to their intravascular volume. And so we're depending on things like blood pressure, heart rate, and symptomatology to know if the ultrafiltration is excessive or not. The pediatric lines for the 2008 are 73 mils, and then when we get up into the 5008, and this is where the weight restrictions come in, the pediatric lines are 108 mils, and the adult lines are 136 mils. So lots of math involved for us when we're designing a circuit. We use Tego Connectors. This is partly for safety. If you're not familiar with these are high-flow Lurlock connectors. So the dialysis lines actually connect directly to the Tego connectors, and these have been shown to reduce the incidence of catheter-related bloodstream infections, which is important when you're relying on catheters. And I have to say that it's quite amazing that we have actually very few central line infections, despite the fact that these are a lot of grubby little toddlers, as you'll see. We know if anybody's got children knows what a cesspool a child is when it comes to infection, yeah. So we have to do some math, and we use the following calculations. Neonates have a blood volume of 100 mils per kilo. From a month of age up to 16 years, we use 80 mils per kilo, and in the older kids, 70 mils per kilo. It's really not a problem to design a circuit for somebody who's 20 or 30 kilos in our books. So I'm going to show you some patients that'll tug at your heartstrings, I'm sure. So this is Nicholas. He's 5.8 kilos or 0.32 meters squared body surface area. So he's relatively big for a baby. Once we get down to around 3 kilos or so, we have the problem where the extracorporeal circuit is too big and we have to prime with blood. And so once we know that the patients are stable enough, we'll push that and see. Sometimes we'll start with an albumin prime and then ultimately go to a saline prime if they'll tolerate it. So Nicholas has an FXP dialyzer, neonatal lines for a total of 45 mils and 9.7% body surface area. And he's got an 8 French med comp, which if you look at that chest x-ray is pretty big. Some of the lines have a stepped configuration at the end, and sometimes that step is just too big to get both lumens of the line in the right place. So even though we're not supposed to, there's lots of things we do in pediatrics that we're not supposed to do. We have to trim the end of the lines when the interventional radiologists put them in order to get them in the right place. When you're a baby, and this is true for small people in general, you need more dialysis, and you need more dialysis if you have no kidney function. And so it would be quite typical to have a baby on dialysis for 6 days a week, sometimes 7 days a week when they're first starting off. So it's a big burden of care for both the healthcare team as well as the parents. And babies don't tolerate more than about 2 hours of dialysis, so that would be our average session. They start to get fairly antsy, and once they start to move, then the access gives us problem with flows. So we go for shorter, more frequent dialysis sessions. This is Asa, who's proudly pointing out her 2008 machine and demonstrating her 10 French MedComp central line. And she's a great example of the fact that if you give kids enough dialysis, they will grow beautifully, as you can see from her growth chart. And we're just working her up to go to transplant now. So she's got a 10 French MedComp access, and her circuit volume using an FX40 and pediatric lines is just 12% of her extracorporeal volume. She's dialyzed 6 days a week for 2.5 hours. She has a nap on dialysis and wakes up ready and raring to go. As you can see, she's on her way out of the unit. And you should hear the giggles and the running around some days. So it's really fun to work in a pediatric unit. This is Zara, who, if you can see there in front of her, she's got an iPad, and she listens to Bollywood videos almost the whole dialysis treatment, and she's teaching me some great moves, but she's way better than I am. So she's 17 kilos. She's got a total circuit volume of 10% using an FX40, and the bigger pediatric lines on the 5008 machine, and you can see where her access sits. She's got residual renal function. She's quite high output, so we actually don't need to ultrafiltrate to her at all. And we can keep her in the chair usually for 3 hours. And so she's dialyzed 3 times a week for 3 hours. But, you know, it takes a village to look after these kids and to keep them occupied on dialysis. And the teachers come. They have at least an hour of schooling, all of the kids that are school age. Sorry. So Julie is about the same size as Zara, but a very different body configuration, and she's a very going concern. So she had a full-blown anaphylactic reaction to the FX40 dialyzer, and so she's on the Polyflux 6H, which is a slightly bigger dialyzer, but we're able to get a 12% circuit, which she tolerates very nicely with a 10 French MedComp access. She also has residual renal function, so she gets 4 treatments of 2.5 hours, and that's because Julia really can't sit in the chair for 3 hours. And so what you can't see in the corner there, that red sleeve, is from A. Lebu, the therapeutic clown, who's lots of fun. He comes in to visit and blow bubbles and keep the kids occupied. Jakai is more like your small adult. He's 32 kilos. With a 1.1 meter squared body surface area. So he's also on the 5008 machine with a 12 French MedComp. He's got an FX60 dialyzer. So his total circuit volume is 182 mils or 7%. So if you've got a range of dialyzers, it's really no trouble to get an appropriate circuit for a patient that's over about 25 kilos, at least for a pediatric nephrologist. The actual prescription and the blood flow and so on that the patient gets is really determined by their needs and by their blood chemistries. And so typical for a child like Jakai, he would be getting a 6 mil urea clearance, which the blood flow would be about 6 mils times his body weight, or 190 mils. And finally, we do have patients at home. So this is Caitlin bedding down for the night with all her stuffed animals. She's got the BioFlow Duramax, which you've got a picture of there. She's on the 5008 machine at home. She runs a dialysate flow rate of 300 mils per minute, and she gets 6 nights a week of dialysis for 7 hours. So she feels great. She can eat what she wants and drink what she wants. And we actually have to add phosphate into her bath. And you can see that for an adult-sized patient, that's quite a small percentage of her extracorporeal circuit. So to talk about adequacy, the 2006 KDOQI guidelines stated that for children, they should have at least the same delivered dose as adults and maybe a bit more if they're growing. That was all fine and dandy. The 2015 guidelines didn't really mention children at all, other than to say that smaller patients, especially women and children, are at risk for underdialysis. And so there's been some papers that have looked at surface area normalization of a standard KT over V as a better marker of dialysis delivery in small patients. And this came out of the HEMO study when they reanalyzed the effects and looked at if you surface area normalize the KT over V, that women in the high dose group were really only getting the same amount of dialysis as men in the standard dialysis group. And so this has been looked at in a couple of ways in pediatrics. There was a study from 2 different centers, one in Israel and one in North America, that looked at 34 children only on 3 times a week conventional dialysis. And when they surface area normalized the standard KT over V for these patients, discovered that the majority of the small patients, particularly the really young ones, did not achieve that target of 2.45 per week. And modeling suggested that, in fact, you needed more than 8-hour sessions in order to achieve that target. And that really speaks to what we do. We measure a KT over V, but we basically give the kids as much dialysis as they require in order to keep them growing. So in summary, a hemodialysis circuit and access can easily be adapted for small adults using some of the guidelines from pediatric centers, and we're only a phone call away. And small adults are at risk for underdialysis, so one should think about surface area normalizing their markers of dialysis adequacy. So So I'm going to move on to peritoneal dialysis. And I will say that I think, like here in BC, we really aim to have most of our kids on peritoneal dialysis whenever possible. We had the same problems with geography that you have here in British Columbia with the vast distances away from dialysis centers, and the fact that all of the dialysis centers are scattered along the lower part of the province. Ottawa, Toronto, Hamilton, and London are the only places where there are pediatric nephrologists. So if you live in Kapuskasing and you are 10 kilos, there is no adult nephrologist that's going to touch you with a 10-foot pole. And so you're on PD or you're moving to Toronto. And so whenever possible, we want to move people towards PD primarily because there's less time missed from school, so it's a better rehabilitation. So in order to do PD, we need an access, we need to choose a modality, we need a solution, and we need a prescription. And I'll spend a little bit time talking about dwell volume, which is important in small patients. Access is, as people know, defined by the intraperitoneal portion, whether it's straight or coiled, and by the subcutaneous configuration, which can be straight or arcuate, and can be a single or a double cuff. And so we use primarily the swan neck coil catheters. These are actual catheters side by side that you can see. The neonatal catheter is 1.7 mils in internal volume, so about half the size of the adult catheter. And you can put a neonatal catheter in. Our smallest baby so far was 1.8 kilos. One of the things that's particular to pediatrics when you're putting in a catheter in an infant baby is the high incidence of patent processes vaginalis. So it's 80 to 90% in newborns, still 70% at 3 months, and 50% at a year. So whenever possible, unless the patient requires urgent dialysis, the surgeons will put the catheters in laparoscopically and will actually look for the inguinal, at the inguinal orifices. And if there are hernias there, they'll fix them prophylactically, and if they do one side, they'll typically do the other side. And so that allows us to use the catheter right away without worrying too much about hernias. There are some technical issues. This is a baby that we did recently where the muscle layer is just not big enough to bury that cuff. So in order to have the catheter stay in place, they actually have to suture the cuff into the muscle. And because the subcutaneous tissues are quite small in these babies, in order to give us a good watertight seal, there's liberal use of Tisseal or tissue glue to try and allow us to use the catheters when we need to use them. The guidelines for exit sites say that the exit site has to be away from ostomies, such as vesicostomies, G-tubes, and colostomies, and out of the diaper area in view of the, or easy access to the caregiver. And these are a couple of examples of bellies that are fairly complicated. You can see in the lower left-hand side, there's a G-tube there in the left upper quadrant and a PD catheter in the right lower quadrant. We've got 2 patients with vesicostomies and G-tubes, and we've even had children with colostomies on PD. So it is a little bit challenging to get that exit site up out of the diaper area and away from those ostomies. So I have miracle surgeons. One of the things that's particular to small infants and more cachectic patients is the fact that when you use a 2-cuff catheter, there is an incidence of extrusion of that distal cuff. And so for preference in the very tiny babies, we now use a single cuff catheter, and we usually have a few of those in stock for when we need them. And just like in adults, that distal cuff should be 2 centimeters from the exit site, but they do migrate out. And some of these kids, especially, there's a little baby with polycystic kidney disease, and they have massive kidneys that take up space in the abdomen. One of the things we have to take into account in pediatrics is growth of the patient. And so we typically will transplant fairly quickly, but for patients who are highly sensitized or there are medical reasons why they're not listed for transplant, growth is a good thing, but it can also be a bad thing. So this is a child who, from when the catheter first went in and was nicely situated in the pelvis, has grown 21 centimeters, and now that catheter is up rather high and given us some drainage problems. And so we have to take that into account. Growth was also noted as a problem for the presternal or bathtub catheter when it first came out, and there was a series of pediatric patients that were reported that although there was a redundant length of catheter left in the tunnel, there was a disconnection at that titanium connector in the tunnel that required revision of the catheter, and that was related to growth of the patient. So when it comes to modality, really, it's for most patients, it's a parent choice that drives the choice of modality. And so imagine yourself as a parent having to go into school a couple of times, or at least once during the day, to do CAPD exchanges. So almost exclusively, our patients are on automated PD. And we are currently using the home choice cycler and trialing the Fresenius SleepSafe Harmony cycler. So that it's driven by patient preference. It's driven by the ability to attend school. So you go on dialysis at night and your parent takes you off in the morning and off you go. It's also driven to some extent by the patient's peritoneal transport characteristics. And the other thing is that we're constantly trying to adapt things that were made for adults to pediatric use. So if you take your standard twin bag, which is 2 or 2.5 liters, and you've got a dwell volume of 400 mils or 600 mils, it's actually quite difficult to accurately figure that out if you're doing CAPD. We use the same solutions as you use in adults. We have tried to have one solution for everybody. It doesn't work. We're now using 4 different solutions depending on the machine and the patient's requirements. So I want to talk about the dwell volume considerations. We all know that clearance is proportional to dwell volume, and we want to push that dwell volume as high as we can. But the dwell volume has an impact on peritoneal solute transport, intraperitoneal pressure, and ultrafiltration that are important considerations when you're talking about small patients. So in the late 1980s, Dr. Twardowski introduced the concept of the peritoneal equilibration test, which was a way of characterizing the peritoneum or the solute transport characteristics of the peritoneum. So we got on the bandwagon fairly early and published the first paper on PET in children, which in those days we were using about 32 to 35 mils per kilo dwell volume. And to our surprise, we discovered that about 70% of the children looked like they were high average transporters compared to adults, which didn't make a lot of sense until some bright spark pointed out what was known since the late 1800s, and that was that your peritoneal surface area is actually proportional to your body surface area. And if you look at an infant, their surface area per unit body weight is double that of an adult. And so when the PET was repeated, scaling to 1,100 mils per meter squared body surface area, we saw exactly the same results in children that you get in adults. And so that was one of the first lessons that we learned, is that if you underfill the peritoneum by scaling dwell volumes to body weight instead of body surface area, you create an iatrogenic rapid transport state, which has significant implications. We also know that your dwell volume is linearly related to your intraperitoneal pressure or vice versa. So that for increasing peritoneal pressure, increasing intraperitoneal volume, you'll get increasing peritoneal pressure, and that pressure is related to position. So for any given intraperitoneal volume, it's going to be lowest when you're lying down, intermediate when you're standing, and highest when you're sitting slouched over, like you guys are all doing there now. Sit up straight. That's what Mom said. And we know from measurements that the maximum tolerated pressure is 18 centimeters of water for both children and adults. So Michelle Fischbach, who's a pediatric nephrologist in Strasbourg, was a big proponent of measuring intraperitoneal pressure. And there are studies in adults that say the average adult cannot differentiate dwell volumes if you infuse different dwell volumes into them. So this is very subjective, the feeling of fullness. And it's certainly not possible to determine that in small infants and children. So he set about measuring intraperitoneal pressure using a manometer that uses the patient's own PD catheter, standardized to the mid-axillary line with 2 measurements during inspiration and expiration, which are averaged to give you the intraperitoneal pressure. And he was able to define that based on sort of pressure measurements, that the average dwell volume that certainly a child over 2 years of age will tolerate is between 1,100 and 1,400 mils per meter squared. And there's data in adults that also says that adults will tolerate a dwell volume between 1,400 and 1,600 mils per meter squared, and that about 1,500 mils per meter squared corresponds with the optimal mass transfer area coefficient for solute transfer. And those volumes do have to take into account ultrafiltration as well. So what happens if the dwell volume is too big? Well, first of all, patients may have symptoms. And I have to say, in the babies, they barf. So if the volumes, you go up even 10 mils on the dwell volume in a baby, and you say, how can that possibly be causing symptoms? They throw up. And so we have to go up really slowly when we're scaling those volumes up in the babies. But if the dwell volume is too high, it can be associated with pain or discomfort. It can push up the diaphragms and cause respiratory compromise, especially if you have patients with underlying heart or lung disease. And although we always say that maybe we're going to get hernias, there actually isn't good data in the literature that would support the volume being associated with hernias. The second thing that happens if you push the volume up too high is you get reduced ultrafiltration. And so there's data that says that the intraperitoneal pressure increases between 4 and 6 centimeters of water per liter of fluid that's put into the abdomen, and that for every centimeter of water that you increase the intraperitoneal pressure, you're going to absorb between 30 and 35 mils per hour of water through lymphatic absorption. And so if your dwell volume is very high, then you have to start using higher glucose concentration to achieve the ultrafiltration, which of course we know what the metabolic consequences of that are. And finally, if the dwell volume becomes too high and the pressure is too high, it's actually counteractive for phosphate removal, and we know how good PD is for phosphate removal. We found particularly dwell volume was important when we looked at our data on Icodextrin. So on kids on the cycler, we use a lot of Icodextrin for the day dwell. And what we found was that the small children were absorbing the Icodextrin, so it wasn't kind of a negative effect, but if you didn't have urine output and you were absorbing some of your day dwell, then we had to take that extra fluid off at night, and it was compromising solute transfer. So when we looked at the day dwells, the cut point was really at about 550 mils per meter squared. And that makes sense because we do know that your recruitment of the peritoneal membrane goes down when you stand up. So although we're trying to keep those dwell volumes lower during the day from a comfort point of view and a pressure point of view, it actually impacts recruitment of the peritoneal membrane. And so if your patient is absorbing Icodextrin, if you're using it, go to a bigger dwell volume during the day. If you use a lot of Icodextrin, you'll start to see the allergies. I would estimate it's probably somewhere around the 5 to 10% mark. We certainly see eosinophilia with it. And there's 2 reactions that are described. One is a kind of a generalized maculopapular eruption, and the other is a peculiar reaction of peeling of the fingers and toes in the absence of any kind of fever or infectious illness. So the APD considerations then, once you have decided on your starting dwell volume, is how long are you going to treat for? And again, infants require more dialysis than older children. So a typical infant is going to be on dialysis for 12 to 15 hours a day, a school-aged child around 10 hours, and the teenagers, particularly if they have residual renal function, about 8 hours, and life's all about compromises, right? The number of cycles and the average dwell time is going to be determined by the peritoneal transport characteristics of the patient and their ultrafiltration requirements. And we will typically, for most patients, have a dwell time, which is quite different from the adults, of around an hour, so somewhere between 50 and 70 minutes. As the kids get a little bit bigger, we can push those dwell times a bit, as long as we can keep the dwell volumes up. And as I mentioned, in kids, we're aiming above 2 years of age, 1,100 to 1,400 mils per meter squared is tolerated, and under 2 years of age, we're aiming for 800 mils per meter squared, but we quite frequently don't get there in the babies because of symptoms. When you start to think about physiology and peritoneal dialysis, we're always at cross purposes. So if you look at ultrafiltration and small solute removal like urea and potassium, shorter dwell times are better. If you look at phosphate removal, longer dwell times are better. And so there's been work done that's characterized 2 times during the dialysis cycle. One is called the apex time, which is the crossing of the DP urea curves and the DDO glucose curves during a peritoneal equilibration test. And that's thought to be the optimal dwell time for ultrafiltration. And the second is the phosphate purification time, which is when you get a DP phosphate of 0.6. And that's the optimal dwell time for phosphate removal. But as you can see, the DP for phosphate, or that phosphate purification time, is typically 3 to 4 times the apex time. And so this competing interests is behind a new therapy that's gaining some traction, although we don't have a lot of experience with it in pediatrics, and that's called adapted PD, where you have, during an automated dialysis session, a couple of low volume, short time cycles, which favor ultrafiltration, and then several longer dwell, bigger volume exchanges. And in order to do that, you need a cycler that's actually able to program individually cycle time, dwell volume, and glucose concentration. And the cycler that we don't have any adapted PD experience yet. We're just trialing the Sleep Safe Harmony, but it's new technology that's able to do that adapted PD. So I'm going to finish off with showing you a couple of cuties. This is Olivia, full of attitude, who is on CCPD. She has 12 cycles in 14 hours, so a relatively long time on the cycler. She has a fill volume of 500 mils, which is 925 mils per meter squared, and has an average dwell time of 59 minutes. And she does not have a day dwell for a number of reasons. Paige is more like your small adult. She's 27.6 kilos. She does have some residual renal function. She gets 7 cycles in 9 hours on the home choice with an average dwell time of 69 minutes, and her dwell volume is 1,165 mils per meter squared, and she gets an Icodextrin day dwell. That's just under 600 mils per meter squared. So the PD prescription in pediatrics can be, or some of the principles can be adapted for use in adults. Obviously, a PD prescription is not just about dwell volumes and dwell times. It has to take into account residual renal function, comorbidities, patient choice, all of these things. But it is possible for lessons learned in pediatrics to help you in adult prescriptions. So I'd like to say a huge thank you to the children who've allowed me to use their images, who've made lots of funny faces for the camera, and who've given me the great privilege of looking after them over the years. Thank you.
Thank you very much. That was outstanding, and I think we have some time for questions. They're not coming up here, but I see them on my phone. Can we bring them up on the screen so Dr. Harvey can see them as well? They're challenging, I'm warning you.
Oh, no. I'm up for it. I have to take my glasses off. Okay. So it's a great question. Would amputations create a small adult? I guess it depends on whether you're talking about PD or hemo. In PD, the amputations would not affect the peritoneal surface area, so you would still scale your peritoneal dialysis accordingly. I think when you start to talk about, if you're looking at KT over V in patients with amputations, and sadly we've had some of those recently, you have to adjust your surface area for the amputations when you're doing your calculations, because that relates to your muscle mass. And so in hemo, yes, you do have to account for that. I guess if you're going to calculate a KT over V, I hesitate to say that for PD patients because Joanne Bergman will kill me. And so if you are doing some markers like that that are going to involve a look at urea or creatinine generation, then you have to take that into account in an amputee. Okay, how long is the transplant wait for pediatric patients? And the youngest age pediatric patients can be transplanted. So that's going to differ across Canada. I think in Ontario and I think in BC as well, there's a pediatric advantage so that we get first crack at one kidney for any donor under, I think it's 35 at the moment. In our hands, in order to be eligible for transplant, you have to be 10 kilos and 82 centimeters. So you can't be 10 kilos this way. You've got to be long enough for there to be space in the abdomen. And we can put a good-sized adult kidney in a 10-kilo kid with a good outcome. There are lots of technical challenges when you transplant a small child like that, especially if you put a big adult kidney in. They quite often require inotropic support for an extended period of time in the ICU until that kidney is used to the lower blood pressure. But that's in our hands. I don't know if Janice wants to comment in British Columbia. We have the same problems with the wait times are going to be longest for the Bs, shortest for the As and the Os.
Yeah, very similar. Our surgeons want them to be 10 to 12 kilograms in weight, and it's very hard to grow the little ones, so sometimes that takes longer than you would for a child without kidney disease. Yeah.
The next question is, how common is home hemodialysis for pediatric patients? So our criteria is if you're going to need to be on dialysis for certainly for more than 6 months. So we target the kids that have lupus, vasculitis, malignancies, the kids that we know are going to be on dialysis for a year or more. And that's the population that if the family is able to do it, that will move them towards home hemo. So we will typically have one, sometimes none, occasionally 2 children on home hemo, but it's a small population. Most common causes of end-stage renal disease, that's going to vary by the age of the children. So in the young ages, we see the congenital abnormalities of the urinary tract, what we refer to Acute. So they're the valves patients, the dysplasia patients. There are also children with autosomal recessive polycystic kidney disease. That would be the big population of infants that come onto dialysis. And then as they get a little bit older, we're seeing the acquired diseases, the glomerulonephritis, the inherited nephrotic syndromes, the congenital nephrotics, or things like the WT1 mutations and so on. Why do smaller people require more hemodialysis? They just do. I don't know. Bigger metabolic requirements. I think it's not that they require more dialysis. I think that it is, well, I guess they do require more dialysis is the bottom line. It's got to do with their volume to body weight distribution, basically. How are we doing? We still have time? We still have time. Yeah. Oh, okay. Do we time the hemo treatments around a nap scheduled for admitted patients? We try to be flexible whenever we can, but when your hemo unit is busy, just like in an adult unit, we have to do the kids when we have a nurse to do them. And in our dialysis unit, we're not just doing the hemodialysis unit. Our nurses do all the apheresis, the stem cell collections, and so on. So it's not just about dialysis. So we're always juggling times, plus all of the acute dialysis patients that transition from CRRT to hemo. And so if you've got a dialysis slot, it doesn't matter whether you're sleeping or not. I know when we say let sleeping babies lie, but you're going to come to dialysis regardless of whether you're napping or not. I'm sure that's the same for Janice's unit as well. And is there data on subsequent central venous stenosis with early IJ line insertion? So the IJ lines are associated with a lower incidence of central stenosis than subclavian lines. And I knew Rob Oldall when I was very junior in my career. For those of you who knew Rob, if you so much as said subclavian, you would get like whopped up the side of the head, because we knew even in the 80s that the subclavian lines were associated with stenosis. We use, of necessity, in pediatric patients, PICC lines. We don't like to, but if you can't take blood, you can't look after the patients. And so life is all about compromises when you've got a small child on dialysis. So we don't have good data is the short answer. Okay, I have to read this. Some young hemo patients who are transferred from children's present very low blood pressure during the treatment. How much do you think their cardiovascular system is affected to being on dialysis in such a young age? I think it's probably not a cardiovascular disease. I think that some of it is probably autonomic dysfunction. And we use a fair amount of Midodrine for patients whose blood pressures are low. And we actually see this in anephric babies on peritoneal dialysis. And there is an association with very low blood pressures in infants and children on PD and anterior optic ischemia and blindness. And so we are very careful about trying to keep the blood pressures up. But I think the first thing you have to ask in those patients is, do you have the right dry weight? And the second is there autonomic dysfunction that might benefit from using Midodrine to maintain the blood pressure? Okay, so what length of drain line is used for APD? It's the standard tubing for the cycler. I don't know how long it is. I know many volumes, but I don't know that one.
All right, thank you very much for the great presentation.